I do want to provide a brief disclaimer to all of you that this presentation tonight does not provide medical advice, and the information, including but not limited to, our text, graphics, images, and other materials are for informational purposes only. We advise to always seek the advice of your physician or another qualified healthcare provider with any questions you have regarding a medical condition or treatment. And it's our intent tonight to provide you as much professional information as we can, but please do not consider that to be specific medical advice to you or to your child. With that, let me turn it over to Dr. Correll and Dr. Wahezi, who are going to kick off our presentation tonight.
Thank you, Jim. So I'm Dr. Colleen Correll, like Jim said, and I'm going to start talking, and then Dr. Wahezi will take over after me. So first, I just wanted to say that the majority of the information that we are discussing today does come right from the Centers for Disease Control and Prevention, so the CDC. And you see we have a link there. We'll send the links out after the talk so that you can very easily find this information and get a little more detail if you'd like. So, you know, what we really want to do is give you resources so that you can decide whether you will, whether you should send your child to school. You know, our intent here is not to debate whether schools should be open or not. That could be a whole topic of its own. Really what we want to do is give you tools so that you can make the decision that's best for your child and for your family. And so I wanted to start by saying that, you know, there's no way to ensure that there's no risk at all of getting this virus, but it's important to understand the potential risks and how to adopt different types of prevention to reduce that risk, especially when resuming activities, specifically returning to school. So when it comes to deciding whether you should send your child to school, you really need to weigh the risks, the benefits, and the feasibility of the educational options available in your school and your school district. So everyone has a little bit different, you know, setting that they're dealing with. So again, you know, we're not making the decision for you. You have to make the decisions based upon what you're dealing with in your, you know, community and your family situation. So we're hoping to provide you with the resources so that you can make informed decision. Next slide, please. So why is school so important? You know, I'm a pediatrician, Dr. Wahezi is a pediatrician. You know, we really do believe that school is very important to children, of course. School plays an important role in the students' educational achievement, their overall health and well-being as well. Next, thank you. So aside from a child's home, there's no other setting that really has more influence on a child's health and well-being than their school. So that's why it's very important to be thinking about these things. Next slide. So what the in-person school environment can do, besides providing an educational instruction for the child, is supporting a child's social and emotional skills. That's big. Safety, speech, their mental health. In certain circumstances, they can provide reliable nutrition and opportunities for physical activity. And while, you know, distance learning is important in crisis situations, so, you know, you can't always get all of those other things from distance learning. So sort of to just make sure we all have a little bit of just very basic understanding of COVID-19, I think it's important to just go through a few things so that we can understand what we're talking about when we're talking about weighing risks and benefits of going back to school. So first of all, I just want to talk about, well, what does COVID-19 even mean? Because you hear COVID-19, you hear COVID, you hear coronavirus, and maybe many of you know this, but I just want to make sure we're all, you know, at the same point here. So the CO for COVID comes from corona, the VI comes from virus, D comes from the word disease, and then 19 comes from the year that this virus started. So COVID-19 is basically just a mashup of some words that mean that bigger phrase. And then how does it spread? Because maybe you've heard different things. So mainly coronavirus spreads from person to person through respiratory droplets when an infected person coughs, sneezes, or talks. These droplets then land in the mouth or nose of someone nearby. Sometimes it may be inhaled into their lungs. And this spread is more likely when people are in close contact with one another. And, that's why we say, standing 6 feet apart, because that would decrease that risk of those droplets landing. The other thing I think is important to understand is this term community spread, because I think you will hear a lot about it, and you probably have heard a lot about it, especially when talking about opening schools or opening other things out in the community. So community spread means that a person has been infected with a virus in a certain area, including some people who aren't sure how they became infected. So maybe they're out and about and then they got it and they're not even sure how they got it. So I think that's important to know. And what do we know about COVID-19 in children? So as everyone knows, COVID-19 is a new disease, so data really is limited at this time, but we do know a lot more now than we did back in March. So from the limited data that we have at this point, we do know certain things. So one, we know that children are less likely to get COVID-19 than adults. We also know that if children do get it, they're less likely to become seriously ill. So that's great for children. So data as of July of this year showed that 7% of reported COVID-19 cases and less than 0.1% of COVID-19 related deaths in the US were in children. And data from other countries suggests that when children become infected, it's usually from a family member. So it's usually due to that close household contact and less likely due to something out in the community, but that's still possible, of course. And then we know that for children and adults both, the risk of getting COVID-19 is also influenced by the intensity of transmission in the community. So of course, if there's a lot more COVID going around the community, you have a higher risk of getting it. Next slide. So when schools are considering reopening, the CDC has recommended strategies across 4 key areas to reduce the spread of COVID-19. So the first one is promoting behaviors that reduce spread. So for example, practicing the social distancing, washing hands, wearing face covers. So those are things that everybody should be doing. Schools should be promoting that too. Number 2 is maintaining healthy environments. So ensuring that there's proper ventilation in the building. Cleaning and disinfecting frequently touched surfaces. That's an important one in schools. 3, maintaining healthy operations. So for example, staggering schedules, keeping students in small groups. Number 4 is preparing for when someone gets sick. So what if a kid or a staff member or teacher does get sick? What are they gonna do? How are they gonna attack that? So I think something you certainly can and should do as a parent is look up your school or your school district. Do they have any kind of guidelines that they've written up of how they're addressing these things? I know I'm a parent and I'm going through this too with my kids, and I've seen that a lot of the schools in my area do kind of address these on their website. But if they're not, you should feel that you can contact your school district and ask them what they're doing. Because I think you need to be informed in order to make these decisions. Next slide. And then I think Dr. Wahezi is taking over at this point.
Thank you. Thank you, Colleen, for the introduction, and thank you again to CureJM for inviting us to be here. So we just wanted to shift gears a little bit here to talk about what is the risk to our patients. And so the CDC has put out a summary that talks about people who are at increased risk of getting COVID-19 or people who are at risk of being severely ill from COVID-19. And when they have these lists right now, it's reported as people of any age. But again, in general, we think children are at lower risk, as Dr. Correll had mentioned. But the ones that are listed here, I just wanted to point out of these conditions, the one that's probably most relevant to us when we think about our kids with JM is the immunocompromised patients from solid organ transplant. So patients who get solid organ transplant are really considered one of the most highly immunosuppressed non-cancer patients. So these are people who are receiving heavy immunosuppression, which hopefully most of our JM patients are not receiving this degree of immunosuppression, although certainly some may be, and we do use some medications that are used in solid organ transplant. So it is something to take into consider that this group is considered high risk on the CDC list. Next slide. There's also a category that talks about people who might be at higher risk. So it's not as clear, but we also still should take precaution. And this list is probably even more relevant to most of our patients. So here I want to point out that, again, it lists being immunocompromised as a possible risk factor. Again, talking about transplant patients or those who have innate immune or have other immune deficiencies. And then it also includes the use of corticosteroids. And so this is something that's very relevant to us and our patients. There have been some reports suggesting that using higher doses of steroids could be a risk factor. So that's something that you might take into consideration about your child. The other thing that I wanted to point out here in terms of the considerations are potentially patients who have lung disease, particularly if they have fibrosis, may be considered at high risk or higher risk, and certain members of certain racial and ethnic groups might also be considered higher risk. So something else to take into consideration. Next slide, please. So what about specifically our patients? So in May of this year, the ACR called for a task force to develop clinical guidance for providers who treat children with pediatric rheumatic disease. And our charge in this effort was to review the literature that's out there, the medical studies that have been performed related to COVID-19, and provide recommendations based on the available evidence that's out there. And these guidance statements were just published in late July. Next slide. So I wanted to just bring it up so I can tell you a few points that came out of the guidance statements that might be helpful to you in making these decisions. First, I just wanted to point out that this task force consisted of 7 pediatric rheumatologists. We had 2 pediatric infectious disease doctors to certainly help out with understanding what we were recommending and making sure that that these recommendations were coming both from us and from the infectious disease community. We had an adult rheumatologist and we had a pediatric nurse practitioner. We surveyed questions from patients, families, and healthcare providers. We did even reach out to Cure JM in the very beginning to see what questions people had regarding COVID-19 and how it impacted our children with JM. And we used those questions and to generate larger scale, broader questions to see what can we address with reviewing the literature, what information is out there. We had over 100 questions that we decided we were gonna tackle. And then we went through a literature review and we developed an evidence report. So we looked at everything, or the studies that were out there regarding COVID-19 in children, and we aimed to use these guidance statements based on that review of that evidence report. And then we had a consensus building process that we used to help guide these statements. So ultimately, we ended up developing 27 guidance statements that we could offer guidance on. There were some topics that were just not enough evidence to really talk about. So a lot of questions were related to vaccines, things like that, and we just didn't have enough information out there yet to make any statements based on that. Next slide. So I just wanted to point out a few factors that you have to think about when you hear about these guidance statements or think about them. One is that these are, again, this is based on review of the literature and expert consensus. It's not a randomized controlled trial. It's not a study. It's based on expert opinion. And again, just based on the review of the medical literature that's out there. The other things that you have to take into consideration is that every patient is different. And so, we grapple with all of these things every time we make any decision for our children with JM. So there are individual patient characteristics that you have to consider, the underlying rheumatic disease, are there overlapping rheumatic diseases? How active is the disease currently? Is this a patient who was just diagnosed and on heavy medication, or someone who's been in remission for many years? What is their treatment? Are they on one medication or several medications? Are we going up on the dose because we're worried about their disease, or tapering down on the dose? Are there other risk factors like the ones that have been reported from the CDC? And again, like Dr. Correll had mentioned, what is the community spread locally? Because these are all things that are going to influence your decisions. Next slide. So here I just wanted to put in a few of the guidance statements just that I thought were relevant to this discussion tonight. So one of the sort of overarching themes of the guidance that we provided is that after we reviewed the medical literature, we really didn't seem to think that children with pediatric rheumatic disease are at increased risk of getting COVID or of severe COVID-19. We reviewed several articles that have been put out there on hospitalized children. Some were children who were in the intensive care units, which again is less common. Most children are either asymptomatic or mild, but even the ones that reported on children from the intensive care units, those patients had comorbidities, but those comorbidities were not rheumatic diseases. So that was very reassuring to us. Of course, the data is still limited, but that was very reassuring to us. There's also registries that are going on both locally, within some of our institutions and also more globally. The Childhood Arthritis and Rheumatology Research Alliance, CARA, which many of you may have heard of, also has a registry where they're collecting data on the prevalence of COVID. So just seeing if there are children who do get COVID, which there have been some of our children with rheumatic disease that get it, what is happening to them? Are they getting very ill? Are they mildly ill? And just keeping a registry of that information. So, but in general, based on what's out there now and what we know, we think that children with rheumatic diseases should be counseled on the strict preventative measures that have been discussed, but similar to that in the general population. So again, this is a broad statement, taking into consideration everything specific to your child, but to me, this is reassuring that we haven't seen any major signals that our kids are at more risk. Next slide. So with regards to medications, we also reviewed the literature. And so again, our medications are used in diseases, not just rheumatic disease. So there was some more information about the medications that we use. And what we concluded after reviewing the literature is that really what's most important is that we have to control the underlying rheumatic disease. There are more studies that suggest if you have active disease, you're more at risk for infection than any of the medications that we currently use. So in general, we think that we should be continuing the medications that patients are currently on, starting them if we need to, increasing them if we need to, whatever we need to do to really control the underlying disease. That's the best thing we can do to protect our patients. And that, again, it's reassuring that children who are receiving these medications in general don't seem to be at risk for worse disease. The only caveat to that is, again, with the steroids, there have been a few reports suggesting that the steroids in higher doses may be a risk factor. So in the guidance, we kind of say that obviously if someone is extremely ill and really needs the steroids, again, you have to treat the disease. But if there are ways that you can limit the steroids and try to use as low a dose as possible, that really should be the main goal to protect our kids as much as possible. So again, in general, every kid is different. These guidance statements are really, they're reassuring that we haven't seen a lot of signals that are concerning for our patients or for these medications, but there are all these factors that we talked about that have to go into these decisions. And we're going to keep reviewing the literature. So as more information comes out, we'll put out revised versions of these statements to make sure that we have the most up-to-date information to help make these decisions. Thank you.
Well, thank you, Dr. Wahezi and Dr. Correll for that presentation. But before I introduce Dr. Vitek, I also want to just let everyone know that there will be 15 or 20 minutes at the end of the presentations for questions and answers. So as questions come to you and you want to submit them, please submit them through the chat function on Zoom, and we will get to as many questions as we can tonight. As time runs out, if we don't get to all of the questions, we'll be sure to get answers to you individually over the next couple of days. With that, let me introduce from the CDC, Dr. Charles Vitek, who is, as I mentioned earlier, a medical epidemiologist who has been working on COVID-19 issues for roughly the better part of this year. Dr. Vitek.
Yeah, thanks very much. Since March, I've been working on the response primarily out of DC and focused primarily on the broader issues of transmission patterns and the evolution of what we've been seeing with the way the disease has involved different groups of people. So I think that's what I'm going to focus on here. And what I'm going to say related to schools is focused around these broader issues around transmission patterns. I think that it's important for us to keep a strong degree of intellectual humility because of the fact this is a new agent and we're learning a lot as we go. We have learned a lot since we first began seeing cases here in February and March, but there still remains quite a bit that we don't know. And I think some of this is relevant to what's going to happen with schools, and I don't think we actually can necessarily predict with a high degree of certainty about that. There is some evidence that there may be cross-protective immunity from some other human coronaviruses, but we don't know whether that is enough to make a measurable difference in how people tolerate the disease. We also don't know how much immunity we really need to sort of get protection from a decrease in transmission. As more people are immune, the virus has less of a chance to transmit to other people. And so you get protected by the fact there are more immune people around you. But we don't know for sure what that level is. We have predictions based on what we've seen with other viruses that have the similar degree of transmission as the COVID-19 virus. But each virus does behave differently, and each virus involves different groups of human and their patterns of passing it between them. And I'd say that I think that one of the other things we have to be cautious about is that even though we have seen that the vast majority of young people recover apparently completely within a few weeks, there are groups of patients who have persistent symptoms that as of yet, we don't know whether this is related to lingering effects of the virus, lingering effects from the damage due to the virus. The virus is affecting more systems in people than we initially thought. And I think we have to have a certain degree of caution. There are some studies that have been done, for instance, in Europe, looking at in Germany, looking at a group of patients discharged from the hospital that found a lot of them had evidence of inflammation of their heart, even though they had no clinical symptoms. This was based on MRIs. So I think that study needs to be repeated to see if that's really truly a common finding or not. So I think that on the basis of this, we have to sort of make our best judgment with our current understanding, but realize that things will change as we go along. You know, our information on transmission among children in school-like settings has been evolving fairly rapidly. Initially, schools were closed fairly soon, so we had little data on what happened in congregate settings. There was some data from contact tracing investigations, especially, for instance, in South Korea, which is one of, had formed sort of the basis of our understanding up until just a few weeks ago, which showed that children appeared to be less likely to be infected, much less likely to transmit to others. Similarly, data from Sweden, where they kept schools open, showed that they didn't appear to have any more number of cases, clinical cases, than Finland did, which had closed its schools. And school teachers didn't appear to be at increased risk compared to other occupational groups. So both of that set of data is pretty reassuring that it didn't seem that schools would be likely to be associated with high-level transmission or perhaps with increased amount of clinical disease. Next slide, please. Over the last few weeks, there's been additional data that seems to indicate that there is likely to be more transmission than the previous studies suggested. There is a report of a Georgia camp outbreak that was published in the MMWR week before last, which showed that within 1 week of the camp opening, it had to close again because of a high level of transmission. Ultimately, within that week, about half of the campers became infected. Now the campers were, this was an overnight camp. They were doing many of the things that CDC recommended, but they were not enforcing mask wearing among the children, and which was very rare. There was a lot of group singing and group cheering, things that we know are prone to spread droplet infections. But it ended up with a very high attack rate. in terms of infection spreading. There was not, at the time of the report, there was not any serious disease among the children. Since then, we've also become aware of at least one other large-scale camp outbreak, which involved about 40 cases among children. Although we can't say that this will happen extremely commonly, it does appear that under circumstances where children are in close contact and where they're generating respiratory droplets, there is a chance for significant transmission among the children. Next slide, please. I think one of the other areas to consider, as mentioned by my colleagues, is that you have to take into account the amount of transmission in your local community. The sort of most direct way to make schools more likely to be able to stay open without disruption because of cases of disease is to lower the amount of disease that is circulating in the community. And I think that's actually is one of the primary recommendations in the CDC guidelines on around schools. So what are we seeing across the country? I mean, I think that the map on the right is taken from actually the New York Times. So it's public access, and I'm sure there are other maps that are similar to this that can be accessed in other ways as well. Places with very low population density and are they depicted as clear. So the colors represent places that have significant numbers of people living in them, and then with the darker red being areas that have more intense transmission. And this reflects what we've been seeing over the last basically 2 months, which was a large wave of intense transmission, primarily in the south, the southeast especially, and in parts of the Southwest. For instance, Arizona has been heavily affected, as well as much of California. New Mexico was relatively spared. More recently, there has been a moderate rise in Midwestern states, and I think there's been, we will be seeing over the next few weeks whether the measures that governors and local authorities are putting into place to try and limit that spread are going to be able to keep that from turning into a more severe and intense transmission as was seen in the South. Next slide. I think it's important that parents look at what's going on in the local community. This is data from the state of Georgia's website, where CDC's home in DeKalb County, and basically the Georgia Department of Health provides county level information. So for each county, the state map is color coded by county, and then for each county, they show you what is in the pattern of reported cases that would help you to tell how intense is transmission occurring and whether or not cases are rising or falling. Because I think if the situation is that transmission is currently moderate, but cases are falling and the test positivity rate is low, and there are the systems in place to deal with the cases that arise, contact tracing and adequate ways to reach them. I think that that's a different picture than if those factors are not in place. I think that many states are providing this kind of data. And if your state is not, I think it's reasonable to feed back to the State Department of Health. And there's been a lot of federal funding that's going out to try and help states develop these sort of public-facing information portals. And I think it'd be useful if you're not able to access something like this to let your state know that you desire it. Next slide. I think then we switch into the matrix here. Did you want me to present that?
No, it's I'll present that, but I think we just wanted to get Michelle to present on how a parent's been making decisions.
Sure, great, thanks.
Great, thank you, Admiral, and Michelle, over to you, and then Andrew will cover just some brief information on the CDC decision-making matrix, and then we'll open it up to question and answers. Michelle Best, who I think is known to many of you, a longtime Cure JM leader and volunteer here in the Washington, D.C. area, conducted some exhaustive parent-based research, if you will, when looking at the pros and cons, if you will, of sending her own children back to school here in the Washington, D.C. area. And she's going to share a little bit of the process that she went through in making that decision. So Michelle, over to you.
Okay, so in making this decision, I think the first thing, obviously, that we need to do is to make sure we have clearance from our rheumatologist or pediatrician. I'm assuming that juvenile myositis, I really recommend connecting with your rheumatologist if you have any concerns. So anything I say is going to be assuming that you have clearance from your rheumatologist to be attending school. And then you need to decide what your personal comfort level is with having your child attend school. If that is going to cause you and your family an incredible amount of anxiety, then you're not necessarily making the best decision for your family, because you're throwing your family into a very anxious state. And you want to make sure that your child, when they attend school, that it's a safe thing psychologically as well as physically. So the first thing to do is, obviously, and this was mentioned before, check out with your school district what their plan is. Are they doing, many school districts are doing what's called a hybrid plan, where you go to school 2 days a week and then you're home another 2 days a week. If you're doing home learning during those days home, is it synchronous or asynchronous? And you may have heard those terms. Those were new to me back in March, but they are now key terms in our world of education. So synchronous learning basically means live learning, as in your student is being taught live from a teacher. And right now that's considered, you could be in the classroom, but typically you think about it as being, right now we are having a synchronous Zoom meeting, as in we are speaking to you live. Now, anybody who watches this next week, it will be asynchronous. This will have already taken place. You're getting the same information, but you're not watching it live. And live instruction can be very important for students in order to be able to maintain interest, because you can have a back and forth with your teacher and with your peers. Asynchronous learning, again, often that's just information that's presented to you. You know, you have a list of assignments to do and videos to watch, and it can be very well done, but can also be very hard for students to sometimes attend to. So you need to consider your child's learning style. How do they respond to asynchronous learning? How do they respond to synchronous learning? What is going to be the most important thing for them in order to be able to get their work done? Also consider, if your child is at school, they should probably be wearing a mask at school. How comfortable are they wearing the mask? I've seen lots of cartoons and pictures of kids having thrown their masks on the floor, just not wearing the mask. So compliance and considering whether or not peers will continue to have masks on. You really need to think about your comfort level. What if the peers don't have masks on? What if your child isn't going to keep their mask on? One of the questions that I've asked a couple of times is, what if my child chooses to go to school? And in our school district, we have what's called the hybrid model. And if he goes to school for the 2 days and gets the in-person instruction, which will be kind of distracting right now because everybody has masks on and they're talking about arrows in the hallways and different things. So assuming that he does well and he pays attention, what happens when another family member comes home with COVID? And now my child is at home because they have a family member who has COVID, so we're quarantining, and then they need to stay home after that family member gets well for another 2 weeks. What is your school district offering during that now 3 to 4 week time period that they're home? Some school districts may well switch you into their distance learning plan, and some school districts are not making plans for that. They have two different styles of learning, where you're either part of the hybrid, I'm at school and that's where I get the synchronous learning, and if I'm not at school, it's all asynchronous. or they might be able to throw you into a distance learning plan where you can continue to have synchronous learning. This is an important question because you could potentially have a kid home for a month getting nothing but asynchronous learning, which is a very difficult way to learn. How is your kid getting to school? There's a big issue with busing. Can you drive your student to school? How are they going to be doing that? Are they taking temperatures at the door? You're going to need to prepare your student for that. Different families who are choosing the distance options are creating pods. Those are basically small learning environments that may or may not have a teacher attached with a set group of people who have all agreed to kind of socially distance away from everyone else and create their own kind of learning group. That's something to certainly look at. Something else that I think is important is a lot of our students have 504s or IEPs. 504s is basically a set of accommodations that are provided to our students for their learning. IEPs take it a step further and they provide not only accommodations, but they provide actual teacher-led instruction for reading or writing, or could be mental health, or for attention. All of that is going to continue. Don't let your school systems tell you that they're not providing for their accommodations or their special education services during that time or during this time, whether you are choosing the distance learning through your school system or if your student is at school. All of that should be provided, if not prioritized. They're talking about prioritizing some of those students for when it is safe to go back into school. That has come down from a federal level. So make sure your hours could, our school system has talked about reducing those hours, because our students are usually at school 30 hours a week, and now they're saying we're going to do instruction for 25 hours a week. So they're talking about doing a small cut in the number of hours a student might have. And that's kind of okay, but don't let them come back to you and say, we're giving you half time, or we need to make sure that our students are not left behind during this time. Those are kind of the big things I wanted to hit on. I guess one other thing, what is your student going to do for lunch? I mean, these are all just questions you need to ask. I don't have these answers, but what is your student going to do for lunch? What is most important to your student? Can they relate with peers on Zoom calls and do small group work, or do they need to be physically in a building with their friends? My son's love is singing and theater, and as such, because he's enrolled in singing and theater, he was told, after I did all of this research and everything, I didn't want to be told that he shouldn't go to school, so I opted not to call my rheumatologist until about 3 hours before my deadline, and she called me back before the deadline. So we had our decision, we were told not to, but that was, again, because his love is singing, and he would be singing during the school day. And we couldn't count on them to only be humming during that time. But every student has different things that need to be considered, and you need to look at your own child and find out and decide for yourself what's best. And the other thing I want to say is there is no right answer in this. Choosing to keep your student home for distance learning is a great choice. Choosing to send your child to school in order to do physically in class learning is also a great choice. There isn't a right and wrong here. You need to decide what works for you.
Great, Michelle, thank you very much. It was for that thorough presentation, and I think you've certainly raised a number of issues that many of us perhaps haven't thought through all the way at this point in making these decisions. Andrew Heaton is our Chief Scientific Officer. I know many of you know him. I'd like to introduce him for those of you who do not. Andrew was instrumental, along with Claire Johnston, our communications manager, in pulling all of this together for tonight. And Andrew's going to touch briefly on this CDC guidance matrix and how you can access it through a link.
Thanks, Jim. Well, I think first of all, I need to acknowledge Dr. Correll, Dr. Wahezi, and Admiral Vitek for, while I may have pulled this all together, certainly it was their combined intellect that brought all those components into such what hopefully was a nice presentation for everybody. And my aim just in the last few minutes before we go to the Q&A was, how can you draw all this information together that we've just been directed to? And there is a beautiful decision-making tool that's available from the CDC. We're going to put out the various links to this, but the decision-making tool really ensures that, as Michelle said, there's no wrong answer and right answer, but when you're trying to arrive at your individual answer, it's important you don't have any information asymmetry. What I mean by that is that you really make sure you're assessing all the key components that Dr. Wahezi, Dr. Correll, and Admiral Vitek actually just discussed. So it very much goes through a risk-based approach, and what are the most critical aspects. As Admiral Vitek said, it's really important you access what is the local community transmission in your county. That data is available. That certainly feeds into this decision-making matrix. As Dr. Wahezi and Dr. Correll were intimating too, what is the status of your child's disease? Are they active? Are they inactive? What's their medication regime? Are they on an upward trend? Are they on a downward trend? That plays into this decision-making process. Then critically, when you're considering vulnerability, it's not just the vulnerability of your child. Don't forget, as Admiral Vitek said, and as also Dr. Wahezi and Dr. Correll mentioned, it's really important to consider, is a family member, are they undergoing chemotherapy? Has somebody just had an organ transplant? All those things. So those close contacts, they also feed into that decision-making process. So the checklist is, as everything that comes out of the CDC, is extremely well thought out. It's very thorough, but I think critically it's not too long. It looks at those critical aspects, as Michelle just mentioned. What's the school plan for opening and returning to school? What's the plan around some things like, lunch? What's the plan around getting transport to and from school? Then it looks in some detail at, virtual learning modes, if they're in a hybrid mode, etc. And then it also asks you to consider, what are the academic and social and emotional well-being aspects associated with either sending your child to school or not sending your child to school. So as I said, we will send the link through for this. We didn't want to go through this in alarming detail because it is relatively easy to find and it is relatively straightforward. So rather than get into the weeds, so to speak, with their decision-making tool, this is effectively what it looks like. You can download it and you can fill out your own matrix. So I think as all our presenters have been emphasizing, this really is based on an individual county, an individual school, an individual student going to back to school. All those risks have to be considered. So as Michelle said, you arrive at a point whereby you're comfortable and confident that you've made the right decision. So I think this CDC tool will really help ensure that you don't miss any of those key aspects that our presenters have just been talking to. So a lot of the questions are relatively straightforward, and some of them may require you digging into individual school environments as to what they're doing when they're opening school. Are they measuring temperatures at the door? What are they doing with PPE? Asking all those questions, but getting all that information so you don't have information asymmetry. That should hopefully get you to a position where you have much more confidence in making that decision and obviously discussing it, as was emphasized, with your pediatric rheumatologist, just to ensure that everybody's comfortable that they're making the right decision, armed with all that correct information. So as I said, Claire is going to ensure that we get that link out to this particular document, but it's very straightforward and it does bring together really nicely what all our presenters have actually been talking about today. So I think that's probably all I really need to say. And I think, as Jim said, what we're happy to do now, while we've got such a fantastic panel on board, is to open this up to questions. So for those that aren't quite so familiar with Zoom, if you go to the bottom of your Zoom little window, you should see there's a little chat box. And if you open up the chat box, you should then be able to see somewhere where you can type in questions. We just felt it was better if you submit questions via the chat tool so Jim can read them out, rather than having 63 people all trying to talk at once, which may sound a little bit crazy. Thank you.
Thank you, Andrew. Appreciate that presentation. So the first question, and I'm going to amend it just slightly. The in question, this is really, I think, for Dr. Wahezi and Dr. Correll. Is there an increased risk of flare in a child in remission from COVID-19? And I'd like to amend that to have a sort of a two-part answer for a child in remission or a child who has active disease.
I can take that. So I think, you know, just like anything, we do have to be careful in what we know and what we don't know. And there is still limited data like we've talked about. But I think with any infection, that's always a concern. Anyone who has a disease, whether it's in remission or not in remission, in the event of an infection, we do worry that that can cause a flare in their condition. Also, in some scenarios, if you were to get COVID-19 and we held your medications because you had an active infection, that in and of itself potentially puts you at risk of flare of disease. So I do think that is one of the concerns that comes into play, certainly. And again, I think in general, when we're making decisions, our goal is to make sure that patients are in remission and remain in remission throughout this process to, you know, optimize, if they were to get sick, what that, you know, downstream effect might be.
Thank you. Second question, again for either Dawn or Colleen. If the worst happens and my JM child contracts COVID-19, what information should we be sure to convey to all of the medical caregivers who are treating her during this time?
I guess I could take this one. Well, I think, you know, two things are important. One would be to make sure that your primary care doctor knows what that, you know, that if you have COVID-19, what your child's underlying disease is, and also what the medications they're on. But also then what we've been telling our patients in my clinic is we as the pediatric rheumatologist would like to be notified immediately as well. And so, you know, I just like we were saying with these sending your child to school, I don't think there's a one size fits all of what we would do if a child were to get, with JDM were to get COVID-19, but we would be part of that decision making. So I think just making sure everybody who's a primary part of your child's healthcare team knows, and making sure that they're communicating with each other. I don't know if Dr. Wahezi, if you'd add anything.
Yeah, I mean, I definitely agree with that. And I think in general, when it comes to sort of anything medical that happens to our patients, we always kind of want to know, because there is so much that's surrounding it regarding, you know, their underlying disease and their medications. The only other thing I would add is with regards to steroids, like that might be something that's even more important for us to know, because even though we might hold certain medications, if your child were to get COVID-19, we're always very careful, as many of you might know, in terms of like steroids. We wouldn't abruptly stop the steroids because there are risks inherent with that. So just even more of a reason in terms of what to do with their medications, you know, we definitely would want to be notified. So I agree completely with that.
Question for Dr. Vitek. Are the vaccines that are moving through the FDA process live vaccines, killed vaccines, or both?
Yeah, none of them are live vaccines that I'm aware of. I mean, all of the leading constructs are coming. Well, there's several different flavors. One of the flavors is a sort of piece of the RNA, just sort of coding for a short stretch of the the viral structure. That's sort of one of the leading candidates. The Moderna vaccine is based on that. There are inactivated vaccines that are further back in the pipeline, but most of the first set of vaccines are not live coronavirus vaccines. They're not like attenuated vaccines. They're not inactivated vaccines. They're either genetic constructs, mRNA, for instance, or they are based on a carrier virus that will carry a small segment of the coronavirus RNA. So in that sense, some of the candidates are live, quote, live virus, but they're replication incompetent. They're designed so they can't have multiple cycles of replication. They're designed to just deliver that RNA. So those are the types of vaccines that are in the leading part of the development pipeline.
Great, thank you. Another question for Dr. Vitek. What is your feeling about schools that are not requiring young children to wear masks? The schools in our state's reopening plan allows for this.
Yeah, these are difficult questions, and I think CDC guidelines on this recognizes that it's actually difficult for many young children to wear masks in a sort of consistent way. I think, to my mind, it would really depend on what the background incidence of the disease is in the community. If it was very low, like many parts of the Northeast, I would not be highly concerned. I think in places that have a moderate to high rate of disease, I would not expect that I guess I would say I would expect that this would lead to outbreaks occurring over a relatively short to medium term time frame.
Thank you. Question for Michelle. What should we request for our IEP 504 when it comes to synchronous visual learning and hybrid learning?
I guess it really depends on what the disability is that we're looking at. One example that we did this past spring when we were in the midst of we had asynchronous learning for distance learning when all the schools closed. And my son, both of my sons struggled mightily. One of them got significant help from the school where he had a school social worker call him once a week. He had his case carrier call him once a week, and he had help from a math teacher. And I should say one was a phone call, one was a Microsoft Teams, the others were Microsoft Teams calls, but he actually had multiple touches per week from people from the school. One, just a couple of them to make sure he was doing okay, one to check in on organization, what's your status with these assignments, what's your status with those. These are things that should be written into an IEP or a 504. A lot of your 504s, and one of the things that I didn't mention before, but I think is important, a lot of our school systems, if you choose distance learning, are going to try and toss some of our kids into these larger online courses that are not taught directly, that are going to be asynchronous. And I think those classes are really hard to get your accommodations in, especially if you need reduced workload or turning assignments in late, because they often have these really hard deadlines, and it's really hard to modify a curriculum to make less work. And you can end up, with significant, disagreements over that. And so those are things to go into it up front. If your school system wants to put your child in one of these classes, they need to know up front, if you have these things in your IEP or your 504, that you expect that this class that they're putting your child in will meet those accommodations, that they're not just going to be tossed aside. It's one thing to take one online class and have them not follow your accommodations. That's a problem, but you can overcome it with one class. If they're going to hand you 6 online classes and not meet any of your accommodations, that's a setup for failure.
Thank you, thank you, Michelle. For Dr. Correll or Dr. Wahezi, my son is on 3 medications that make him immune compromised. Is he even more susceptible than someone who was on only 1 medicine that makes them immune compromised?
I can take this one. So I think, again, everything kind of depends. I think certainly being on more immunosuppressive medications does potentially cause more immunosuppression, especially because the medications act on the immune system in different ways. So I think potentially that could be a greater concern because you might be more heavily immunosuppressed. But again, it depends on what those medications are. It depends what stage of illness your son is in. It depends on how active the disease is in. So it could be, there could be someone who is on many medications because they were very ill, and now 3 is sort of backtracking because things have been good and the disease has been quiet. So I think there's just so many factors that go into it. But in the short answer, I would say that yes, potentially being on several different immunosuppressive medications is of somewhat more of a risk than just being on 1 or 2.
Dr. Vitek, what are the set of metrics thresholds that we should be monitoring most closely in areas with current low transmission, like New York City metro area, to see if we should pull our child out of school? For example, positivity rates in excess of 5%. Other metrics?
Yeah, I think currently the only 2 that we have that I think that I think we get a lot of data on and that we could potentially use for this purposes are the test positivity rate, as was mentioned, and the overall case rate. The test positivity rate it does, especially changes in it, as it changes, it can provide a fairly good indicator as to whether or not disease transmission is increasing. And I think you have to sort of, you can't sort of base it on any one day, because the test positivity rate in a locality can vary considerably from day to day, depending on, for instance, if there's a nursing home outbreaks, it might spike upward just on a given day because they test a lot of elderly people and find a lot of disease within a nursing home. But I think if there's a sustained increase that occurs over a period of a few weeks, that it is likely that disease transmission is occurring. There isn't, I think there's quite a bit of debate going on about what is the level that one should consider to be safe. I think if the level is above 10%, there is a lot of community transmission occurring. If there's a sustained level of test positivity above 10%, there's a lot of community transmission. If it's below 5%, it's pretty modest transmission, especially in some places in the Northeast. It's been consistently hovering below 3 or even below 2%. And in those places, there's clearly very limited transmission going on. I think it's in the middle zone, in that 5 to 10% zone, that it is hard to be dogmatic about it. It's going to, I think I would base it basically on whether or not the trends seem to be overall improving or not, as to what decision to make. I think above 10%, it is clear that there's a lot of community transmission going on. Over.
For any of our presenters, what are your thoughts about the safety of outdoor school sports?
I mean, I can, I think, I mean, I think in general, outdoors activities are thought to be safer than indoors, right? That's in general, we're thinking outdoor spaces are better overall in terms of reducing risk of spread. I think it depends on the sport and how close the contact is, and if you're able to wear protection or not wear protection because they're running around. I think it's hard to make generalized statements. And I'll refer to Admiral Vitek if he has other thoughts on this. But I think outdoor activities are good, and we'll encourage the kids to be outside, and we want them to stay active and run around. But certainly there has to be some caution.
Yeah, I think I don't have too much to add to that. I think that clearly something like tennis is pretty safe. I mean, you're not going to be, you can relatively easily avoid being close to somebody. I think something like soccer or outdoor basketball, you're going to be close at periods of time. I think so. There will be some risk. I mean, I think it depends on your risk tolerance. It's clearly better than doing the same sport indoors, but it is unlikely to be risk-free. There have been, some of the states have reported outbreaks, clusters associated with youth league sports, including baseball, for instance, but you don't know how much of that is from actually playing the game versus from being close enough together on the sidelines. Mm-hmm. But in general, it's outdoor sports are clearly going to be safer than indoor. Over.
I think it would be interesting to see if there's been any transmission amongst rowing crews, because that's one of the sports where you are always necessarily close together and you can't get away from each other, and you are going to have a lot of people breathing a lot of droplets around.
Although everybody should be facing somebody else's back rather than their front.
That's true.
Right.
Apart from the coxswain.
We have time for one last question, but I do want to say, for those of you whose questions we don't have time to get to tonight, if you could resubmit those to info@curejm.org and make sure that we have your email address, we will work to get answers to you within the next couple of days. One last question. Can Dr. Wahezi and Dr. Correll comment on the safety of RNA-based vaccine for JM kids?
No. Maybe Dr. Vitek could answer that a little better than I could, or Dr. Wahezi. Yeah. I don't know. That's not my area of expertise.
So I don't think we can say much at all about kids with JM. I think that actually these are a new type of vaccines in general. And I think that up until very recently, there had been no licensed vaccines that had used this technology. It does appear to be safe in the trials that they've done, the human trials of this, and they had also used this previously for, I believe, one of the Ebola virus constructs, and I'm not sure about the Zika virus vaccine. So I don't think we can say anything definitively about the safety in somebody with any number of conditions. In the human trials so far, they appear to have been safe. But those have been with healthy volunteers so far. Well,
to Michelle Best, to Dr. Correll, Dr. Wahezi, Dr. Vitek, thank you so much for your exceptional presentations. I think we're all walking away from this better educated than we were at the beginning. And to all of our parents who are struggling right now with the decision on whether or whether not to send your children to school. Best wishes to all of you in making your individual decisions. I know that for those of you who are yet to make them, that's coming up pretty quickly. So hopefully let's all have a very safe August and a very safe back to school when it does happen. And I look forward to receiving any additional questions you might have. Thank you for being with us.